right, so with those few vaccine updates, we want to go into the bulk of our presentation today, which is going to be talking about improving geriatric patient care collaborations with prescribers and pharmacists. So one of the things that I really wanted to be able to do was to go to the literature and to see what has been done already, or what types of information can we find about ways to improve collaboration. So this was a topic that we received interest in developing a presentation for. And so one of the articles that we found was facilitating collaboration between pharmacists and physicians using an iterative interview process. So this was a qualitative research study as opposed to a quantitative study. There wasn't a survey conducted. It was multiple interviews that happened over a period of time. And then the data was combined together, a very small group of individuals. So it was 8 pharmacists and physician pairings from a variety of community pharmacy settings, and then providers specializing in primarily internal medicine, family medicine, and geriatrics. So very applicable to a geriatric patient population. So the pharmacist and physician pairing were pharmacists and physicians that generally work together. So not necessarily in the same clinic, but pharmacists that would routinely interact with pharmacists and physicians that would routinely interact in caring for the same group of patients. So each pharmacist and physician in each pairing were interviewed independently twice. The goal, as quoted in the article, the goal of these interviews was to identify issues, barriers, and facilitators to collaboration with the other provider. So they took all of those items and they just made lists, tried to identify common themes. After that happened, each of the pharmacist and physician groups were provided a copy of the list that was generated by both their group and the other group. And then after that, the pharmacist and physician pairing were interviewed together once following their individual interviews. And as quoted from the article, they were encouraged to problem solve together, to share resources and infrastructure that would be needed to effectively implement and sustain the project. They were also encouraged to discuss their own ideas for collaboration that may not have been on the lists. So as far as results go, the pharmacists identified needs on a wish list from those initial pharmacist interviews. The physicians identified needs on a wish list from the initial physician interviews. There were 6 items identified from the pharmacists, 11 items identified from the physicians. They did not record how many times an item was duplicated, which I do think would have been interesting to have to get an idea of maybe perceived importance. If more than one pharmacist mentioned something, more than one physician mentioned something. But instead we ended up with individual items identified and listed out. Communicating these wish lists with one another then helped the participants to brainstorm solutions and identify further barriers. There were collaboration barriers that were identified that I think are worthwhile for us to mention and take into account, and to think about how in our own practices we might be able to overcome these barriers. So the first one was timing of patient care issue communication relative to when the patient care was being delivered. And this was seen from both the pharmacist and the provider's perspective. So looking at a pharmacist, well, starting off with a provider seeing a patient, trying to identify what medication-related issues are there, trying to help solve those medication-related issues, perhaps writing a prescription for a patient that the prescription wasn't going to the pharmacy until several days later even, or being picked up by a patient until later. So the care involved required people, it was inefficient because it required multiple individuals to review a patient case over and over again prior to being able to really communicate why the decisions were being made or why something would or wouldn't work. So it just was very inefficient as far as timing goes. And then the other collaboration barrier that was identified was time to provide patient care in general. So both sets of providers felt like they didn't have enough time to adequately provide patient care and to do some of these things that would be really helpful for their patients in improving their overall disease state management, medication use, all of those things. Another article that we found was recently published in the American Journal, or the Journal of the American Geriatric Society. So this was just in August that it was published, and it was primary care clinician and community pharmacists' perceptions of deprescribing. And this was very interesting as well to note, because I think they had a much more robust reporting from not only providers, but also community pharmacists. And they asked several pointed survey questions, which I think could lead to further evaluation or further description of how these barriers or facilitators might be addressed. So to quote, the survey questions address deprescribing experiences, beliefs, attitudes, influencing factors, barriers, and facilitators. This article, I think, provides a lot of good resources for us as we think about how we can improve patient care working together when we're not necessarily always physically in the same space. So the results. These are the survey criteria that clinicians and pharmacists identified as barriers. These are the survey questions specifically. So I have in quotations the exact survey response that patients or that survey completers responded. And these are the top 3 for each. So when we look at clinician barriers, clinicians felt that patient attitudes toward the medications they take was a significant barrier, the most significant. Insufficient time available to spend with patients communicating deprescribing recommendations was also very high. And then difficulty to communicate directly with other healthcare providers, for example, subspecialists, about deprescribing recommendations. As far as pharmacist barriers, we see some of the same things. So we see difficulty to communicate directly with other healthcare providers about deprescribing recommendations. That difficulty communicating directly when that patient care experience is happening seems to be a common theme that we saw from the previous study as well. Insufficient time to spend with patients communicating about deprescribing recommendations, again, similar in both groups. And then a lack of trust between healthcare providers and pharmacists was seen as a barrier. There were also some other things that I felt were interesting that I wanted to include, because I think it's something that we can impact maybe more easily than some of the systemic types of practice models that are hard to change. Finding more time is something that's going to be challenging for everyone in our current healthcare system. But there are some things that maybe we could change that would improve patient care. And these were also listed as barriers by both pharmacists and clinicians. So both pharmacists and clinicians agreed that, quote, lack of education and training related to deprescribing activities, end quote, as well as, quote, lack of access to information in electronic health records are barriers. And this is seen as a barrier for both groups. And just as a perspective about lack of access to information in electronic health records, that went both ways. So often pharmacists working in a pharmacy separate from an organization. So depending on the setup of your organization, your pharmacist may or may not have access to the medical record. And that may or may not result in more phone calls to clarify things that would have been clarified or noted in a provider note, which can be frustrating for clinicians who are trying to keep their time management going as well. Likewise, pharmacists have access to information like refill history. It can be really challenging as a provider to determine what a next step in therapy will be if you're not sure if a patient is actually using the medication as prescribed, or that is difficult to tell what their refill history even looks like for some medications. And so both providers have access to information that the other doesn't have that could be useful in shared decision-making and in providing optimal patient care. So I've highlighted the two here just for emphasis. These two were seen by both clinicians and pharmacists. So time and the challenges in communication. So those are areas where perhaps if you are working with a pharmacist in your community, that you can identify some strategies to help improve those. Maybe you have a discussion with your pharmacist or with the pharmacy that a lot of your patients are using to see if there are ways to improve the ability to communicate deprescribing recommendations or to clarify questions on prescriptions. These are areas where we will likely have to be very innovative and creative to make changes. As far as results of facilitators, so these are things that both clinicians and pharmacists thought would help facilitate deprescribing, that would make their collaborations better. And again, I listed the top 3 for each of them. These are the exact statements that were in the survey. So for clinician facilitators, adequate time to spend with patients to discuss deprescribing recommendations, trust between healthcare providers and patients patient attitude toward the medication they take. So again, some of the barriers we see as facilitators, things that would improve that, improve those interactions, are trying to correct the things that were seen as barriers. Pharmacist facilitators, ability to communicate directly with healthcare providers about deprescribing recommendations, adequate time to discuss with patients deprescribing recommendations, and trust between healthcare providers and pharmacists. So again, we can see commonalities here. And likewise, even though these weren't in the top 3, we still see that there are some things that maybe we can work toward improving that will help all of these things as well. So both pharmacists and clinicians agreed that training and experience with deprescribing, and again, you can see the percentages there, as well as clinical guideline updates that support deprescribing recommendations. We've talked about this in the past too, having some guidance for how to approach the management of patients who are older, because we don't have a lot of evidence for that in some ways. So for deprescribing, so we know when to start medications often, but having a clear understanding in clinical practice guidelines about when it is most appropriate to stop medications for risk-benefit ratio for patients as they get older is not always as clear. Sometimes it is, but not always.